Thank you. I couldn't believe it was about me, but this is our early, very preliminary experience in PANS and PANDAS. So this is really a beginning of something new, like you said, a new era. And just to recall previous lecture, streptococcal infection traditionally associated with rheumatic fever is gone. We haven't seen a patient in the past 15 years. I can remember in 30 years experience, maybe 2 or 3 patients with documented rheumatic fever after streptococcal infection. What I saw in the past 20 years, it's about 10 to 15 patients with post-streptococcal reactive arthritis. It's a child who 7 to 10 days after streptococcal infection develops swollen and painful, but not red, knee or ankle. What I did at that time, following recommendations for post-streptococcal arthritis, I gave non-steroid anti-inflammatory drugs, sulfasalazine in some, as mentioned before, and follow them closely for cardiological manifestations because some of them can overlap with rheumatic fever. What I did next, I gave extensilin, long-acting penicillin for a year or 2, following recommendations from American Association of Pediatrics. That is just my impression, what I saw in connection of streptococcal infection. Another thing that is very important in these 15 kids, parents did not mention any swings or changes in the mood of these children or something else. So it's different genetics of this thing that we are talking about today. What we did, intravenous immunoglobulin in pediatrics, used since 1980s in 20th century, first for idiopathic thrombocytopenic purpura, then substitution therapy for primary immunodeficiency, and then comes immunomodulation time using in Guillain-Barré, neurological diseases. It has to be pulled from the healthy donors. It's monomer. It contains traces of IgA. What is mentioned before, somebody who has complete IgA deficiency can develop allergic reaction to IgA as a foreign molecule. That's important for clinicians to know. And another important thing, it has to be monomer molecule. If it has aggregates of IgG, that children develop severe allergic reactions and inflammatory reactions, brain reactions, meningismus, and things like that. That is very, very well known. Safe for use, there's no transmission of HIV, and in some preparations that are inactivated for 2 times, it's free for hepatitis C. So it's completely safe molecule. What is Mother and Child Health Institute is the largest pediatric teaching tertiary care institution in Balkans, 200 pediatric beds, 24 neonatal and intensive care unit beds, surgery 150 beds, all subspecialties besides neurosurgery. In 1971, this is very pioneer work at the Balkans. Dr. Mirko Mikuška, who was the founder of Pediatric Immunology Department, he was trained by Richard Steen and Max Cooper, pediatric immunologists in the USA, who were considered as the fathers of modern pediatric immunology. He came back from the USA and developed a department. Nothing else existed at that time in the East Europe for 20 years. Dr. Abinun, who worked after Dr. Mikuška, he developed the use of IVIG, first replacement therapy for primary immunodeficiency in 1983. So at least 40 years of experience. First, the use was sandoglobulin. We used them from then different brands. More than 20 children and young adults with PID and HIV were substituted. In 2016, modern use of subcutaneous immunoglobulin by infusion pump were available for children. And then, which is very important, immunomodulatory treatment, 4 milligrams per kilo for 5 days in thrombocytopenic purpura. decreasing of platelets after viral infections in children, well described, very efficacious. And more important, high dose IVIG, 2 grams per kilo for 2 days for Guillain-Barré, Kawasaki disease, shown that is more effective than given 400 milligrams for 5 days in the studies. That is the answer for Dr. Kovačević observation. There are some works in Japan that suggested that 1.5 grams per 2 days in Kawasaki was less effective than 2 grams in preventing developing cardiac abnormalities. So that might be some of the answers. Many known actions of the Ig molecule for modeling inflammation and autoimmune processes is known. I will not repeat. Dr. Kovačević said a lot about this, all the actions known. And how we treated PANDAS, started to treat PANDAS in Belgrade. Initiative came from the patients who reached Dr. Kovačević by mail, and then he sent them the protocol. Protocol including antibiotics, tonsillectomy, and high-dose IVIG. We started at the end of 2018. First patient, October 2018, abrupt initiation of symptoms. Severe headache in school, loss of conscience for a few seconds, no seizures, blinking, gasping, mimicking, tics. Physical examination was normal besides horizontal nystagmus. Early development was normal. Family history, younger brother diagnosed with autism. All the investigations were normal. Throat culture was normal flora, but antistreptolizin titer was increased, 1 in 400. Video EEG normal, heart ultrasound normal. During EEG recording, there was a twitching of arms and legs. He was emotionally unstable when interviewed by psychologists. His separation process and maturation are not developed as expected for adolescent age. So he made clearly regression. He was treated for amoxicillin, had occasional temporal pain, headache, vertigo, tics that were milder during course of antibiotics. On discharge, first hospitalization on institute, he fell on the floor, constant blinking, unable to speak and to walk, and twitching. He came to me to outpatient service following advice of Dr. Kovačević. We gave prednisone 2 milligrams, 20 milligrams per day for 2.5 months. It's about 0.7 per kilo per day. He still had headaches, retrobulbar pain, tinnitus, facial tics, twitching was milder but present, and then tonsillectomy was done following advice in February 2019. He developed suddenly symptoms of neurogenic bladder, voiding difficulty. In April, he received 115 grams over 2 days without side effects, 1.5 per kilo. He started to read and write immediately. He normalized his voiding. Tics disappeared. July 2019, he received the second high dose and had very good clinical response. On follow-up, no obsessive compulsive symptoms, no learning problems, and we suggested penicillin prophylaxis. We cannot find at this time in Serbia long-acting penicillin, so we have to buy it in Bosnia or other countries, which is silly. It's very cheap drug, and my patients, they know that we have to buy the drug from Turkey for the patient. Another patient, 6 years old male, also diagnosed as PANDAS, 6 years of age, tics, handshaking, and stiffness of his fingers. Neurological examination normal. After 6 months, tics, involuntary movements of whole body, gasping, mimicking, no OCD, but when he comes to school, he has to do by force his homework immediately. Haloperidol was introduced and symptoms ameliorated a bit. Antistreptolizin titer found to be increased at 412. Personal history was normal, family history was negative. Following advice, again, there was some involuntary movement of the mandible, chewing. Tonsillectomy was performed in March 2019. Postoperative course was normal. In February 2020, he received 2 grams per kilo without side effects for consecutive 2 days. Follow-up, excellent outcome after 2 years of follow-up. Another 3 patients, anxiety, perseveration, sleep disturbances, PANDAS diagnosed at 8 years of age, antistreptolysin increased, tonsillectomy, prednisolone, 4 doses of IVIG with moderate response. As Dr. Kovačić said, partial. 4th patients, 14 months of age, OCD regression. At 4 years of age, autism was diagnosed. Stem cell transplant, no effect. At 7 years, diagnosis of PANDAS was established by anxiety, aggressive behavior, frequent urination, and increased titer. IVIG 3 doses with good response. So what would I like to point? It is very small experience, but as we see, we have an impression that we can use safely high dose of IVIG in these patients. Okay, I'm missing, this is first presentation that I sent and not second. The second is written Pašić final. But I will tell a conclusion without the slides, just to make it quick. The conclusion is that we see no side effects in these 4-6 patients. Another 2 patients that we gave are patients with mixed behavior disorder, not strictly PANS, and we have only partial response in 1 child. The mother said that aggressive behavior ameliorated after IVIG, but other symptoms that did not improve. We can say at this time that we have observed good safety profile. Just to point out, you have to use good monomer IgG and good product. If you use products of suspicion or of difficult origin, then you can expect some severe side effects, especially if there are not monomers but polymers of IgG in the product. We have not seen vomiting, headache, as observed in the other larger studies. We have not observed any other aseptic meningitis or other complication. And we got the impression that if we have documented case of PANDAS, that IVIG works for at least a majority of symptoms. Thank you for your attention. Thank you.
As usual, extraordinary presentation with examples which we all need to know. So any questions from the audience? Please.
Hello, so my daughter is a patient of Dr. Pašić, and I just wanted, she's using IVIG under his care, and I just wanted to add a very interesting observation that we had with my daughter, because for every dose of, several doses of IVIG that she received, overnight she lost exactly 1 fear. 1 irrational fear.
Yeah, I forgot this to mention because it was on these 2 slides.
Yes.
Fear disappeared, which is very interesting.
But it was very interesting, every dose 1. And we made a list of how many fears we have, and then we went that many doses. So we had a very interesting timeline, and it's totally unexpected. So I just wanted to share this.
Any explanation from you, Professor Pašić? Why did it happen?
Any explanation? I can think that IVIG will help anti-inflammatory, closing at some point auto-inflammatory barrier between brain and blood.
Okay.
So I guess it acts really inhibitory, cytokines network and things in the brain, which covers this microinflammation that is observed in these patients.
Well, it's good because we are a mixture here from physicians and then parents. So the questions from the parents are having, of course, the answer from the physician. Thank you very much. And then there is another question here, which deals with who can make a diagnosis of PANS or PANDAS in Serbia.
Who?
Who?
Neurologists, psychiatrists can make a diagnosis. I don't feel competent that I can make a diagnosis without their help, because they have to run through very, very extensive interview with the parents. Yes. And I don't have qualifications or experience, but I can help in this treatment section.
Very honest question. I wouldn't dare to say that you are very competitive as well. But anyway, a good talking and questions with the parents and physician. It doesn't take 10 minutes. It takes much longer to feel the patient and then to be able to give this diagnosis. So any other questions from the audience? I think I seen somebody. Okay, please.
Hello, my son is 22 years old. He's with autism. And a few years ago, he had some episode in the school when he was going there. Suddenly, he's very calm. He's not aggressive at all.
All right.
And suddenly, he started pulling our hair, and he was aggressive, and he was walking very strangely. We went to neurologist. Yes, and they did EEG. Everything was normal. Lab test was normal. So finally, we discovered that at the school, some children had some rotavirus infection.
Could be a trigger.
It happened about 10 days later that we discovered. Nobody knew what is going on. And at the end, it passed. All aggression and
it was self-limited, all went away,
yes.
Without medications?
No.
Okay.
Nobody knew what was going on. And do you think it can affect him later? Should we
I think that you
something?
should pay attention, maybe check for some triggers. I don't know, viruses, bacteria. Do some PCR testing. It is available at Microbiological Institute at Belgrade. And do the testing, but I don't think rotavirus could happen again. And it's very unusual for older children to have rotavirus. But he was at high school at that time, or elementary school.
Elementary school, yes.
So that's could explain the thing. But I don't think that rotavirus stays chronically. Only in immunodeficient, it can stay chronically. But in children with normal immunity, it cannot stay chronically.
Okay, thank you very much.
Htela sam da pitam, kada je u pitanju PANS, znamo da virusi mogu biti trigeri. Ako je dete sklono virusnim infekcijama koje prouzrokuju regres kad je u pitanju autizam, kako lečiti onda? Može li IVIG tu pomoći?
Ja mislim da ima neko mesto, verovatno. Ali bi moralo prvo se dokaže da se urade, znači, PCR-ovi na viruse koji su danas dostupni, moderni. Verovatno i kod mikoplazme ja bi se preograničio na PCR nego na antitela, pošto antitela mogu da perzistiraju dugo. I to nije ponekada dokaz, ako je neko imao, ne možete da dokažete svežu infekciju ako baš nije imao simptome. Ako nađete IgM, on može da stoji u krvi godinama. Tako da ipak na moderniju tehnologiju bi se bazirao ako može nešto se sazna više. Za respiratorne viruse, mnoge osim COVID-a, nažalost, postoji za neke, za respiratorni sincicijalni, za parainfluencu, grip, ali za ostale ne postoje komercijalni testovi. Znači, za adenovirus, recimo, može. Ali bi vredelo uraditi kod takve dece.
Neka druga pitanja? Evo, ovako malo da svrtimo na jezik. Yeah, please.
Doktore, dobar dan. Doktor Kamićević, pedijatar, Dom zdravlja Stari grad. Nažalost, nema nas mnogo na ovoj konferenciji. I htela sam samo jedno svoje mišljenje da sa vama podelim. Sad, posle ove konferencije, ovde ima veliki broj roditelja, doći će kod svojih izabranih pedijatara i reći će, znate šta, mi smo na konferenciji čuli da bi naše dete trebalo da uradi tu analizu, tu analizu, tu
Ja
analizu.
savjetujem prvo intervju i procenu doktora Kovačevića. Znači, to bi bilo vrlo bitno.
Ali, bez obzira na njegovu procenu, veliki će problem biti u samom domu zdravlja sa pedijatrima, koji će, naravno, sujetno da odgovore na to da ne može roditelj da određuje šta će ona da od analiza. Znači, bilo bi jako dobro, zašto sam se ja sada javila da prodiskutujemo, da vi, kao ipak profesor naš...
Savjetujem analize koje će da...
Vi da savjetujete analize ili da jednostavno informišete pedijatrijsku javnost o ovoj konferenciji, koji su zaključci i šta bi bilo dobro, na primjer, ja sam sada prvi put čula za ovaj rizik od streptokoknih infekcija vezano za decu s autizmom, da nas jednostavno o tome obavestite.
Kako da ne, evo
da svi pedijatri dobiju ovu informaciju, da ne bi bilo problema u domovima zdravlja, a mi možemo da obezbedimo sve ove analize roditeljima da ne plaćaju. Znači, 90% analiza možemo da obezbedimo, jer oni inače sve moraju da plaćaju.
Da vam kažem, specifična virusna ispitivanja ne možete da obezbedite.
Ali nešto možemo.
Za virusna ispitivanja možete da date bolnički uput, pa preko dnevne bolnice u institutu može se uzme krv i da se besplatno dobije.
Može i tako, može nešto u gradskom zavodu, može u Batutu, znači ima i radi klinički centar, hoće da uradi biohemijske analize ako mi pošaljemo. Međutim, nije problem u tome, oni će da urade, ali neko to mora da uputi. Da bi uputio...
Ja ću vrlo rado da uputim. Odnosno moja služba.
Vaša služba da da savet, preporuku pedijatru da to uradi.
Tako da ne, a zato nam je potrebno 2-3 skupa da prođe pedijatrima.
Jeste. 2-3 skupa, ali još nešto da vam kažem, dovoljno je jedan dopis pedijatrima, dispanzerima i tako dalje za celu Srbiju, da ljudi to pročitaju, i to je dovoljno, ali mora nešto da se preduzme.
Važi. Slažem se. Samo sam hteo da kažem svoje iskustvo sa periodičnim febrilnim sindromom. To je autoinflamatorno oboljenje male dece, koji dobiju temperaturu visoku na 39-40, svakih 2 do 3 nedelje. Nepoznata genetika, autoinflamacija se odigrava na nivou krajnika. Nekad se nije znalo za to, nego su se vadili krajnici i bolest je prolazila. A zvala se česte infekcije gornjih disanih puteva. I mnogi u svojoj, znači u tim porodicama znaju kroz generacije da je tata, mama, baba imala slično. I onda kad se zna za to moderno lečenje, davanje kortikosteroida minimalne doze, jedne samo, jedan dan prekine temperaturu ko rukom odsečeno. Da bi to usvojili pedijatri, prošlo je 20 godina ponavljanja i pričanja. I ima još pedijatara koji ne veruju u to. Tako da kažemo, ovo je proces. Ne možemo da kažemo iz jednim udarcem da ćemo rešiti sve, ali znači ako krenemo proces možemo da postignemo nešto.
Hvala vam puno kao od roditelja, hvala puno. Idemo, nemamo mnogo vremena, pa idemo sad drugom, imat ćemo diskusiju na kraju ove sesije opet. Hvala vam puno.